about pathophysiology of diabetes. We've spent more time and focused on type 2, the more predominant of the diabetes. We've talked about that it's primarily it has a great deal of heredity to it, environmental factors or things that people do, usually lifestyle. Whatever a lifestyle they adopt tends to have impact on that, bringing it out maybe at an earlier stage. And that we talked about risk factors for it, how to recognize it. We talked about how to screen it, how to diagnose it. We started talking about how to treat it. We spent time on nutrition, which we'll bring in, we'll see again. And we started talking about how we would engage the person who has diabetes, the things we would cover in our initial interview with them, whether they've already had diabetes or whether we're diagnosing it for the first time. We've also talked about what constitutes diagnostic test, what that criteria looks like. And then we started talking about the drugs. Yesterday we covered metformin and the sulfonylureas, and today we're going to pick up the rest of the oral agents and talk about also the GLP-1s, which are injectables. And then next hour we'll talk about insulin. We're going to talk about basics you need to know about just insulin therapy. How does it come? Because it's very standardized. What's the jargon around insulin? What terms do we use to describe it? Talk about the different insulins. We'll talk about then how do you start insulin in a type 2? Very different than what we do in a type 1. And then the next hour we'll talk about the pathophysiology of type 1. And then you won't have to look at me the rest of the day because I'll be looking at your backs. Okay, then this afternoon, Amy Hughes will come in and she's going to talk about common skin disorders. You see it a lot, so that's why I asked her to do it. So I want you to have some orientation to that. And then Dr. Britton will finish up the day with coping with chronic illness. He's been talking to me about what he's doing for the last few days, so I think it'll be really good. It always is. This is his forte, so I think it will be something you'll enjoy. It'll be something different at the end of the day when your brains are kind of worn. Okay. For today, I have everything ready except I have not updated the objectives, so I'll have to just get those to you this afternoon. So objectives for insulin and for the type 1 pathophys, I just need to look at those and redo them. So I saw that Professor Reggio reposted her lab medicine. Okay. And I looked through that. There are some discrepancies. For the most part, it's what we talked about, but there are some discrepancies between the cutoffs and what they consider normals compared to what I gave you. Some of it just reflects probably that, I don't remember the lab medicine book, it's probably just an older version. So we're going to go with what I have. I will give you a new handout on that and objectives for it, so as I promised. But it may be tomorrow before I get that done. I'll try to get it done at the end of the day, okay? And I still haven't decided how many questions to do. I'll probably wait until I just see what the information is, the volume of it. So questions about anything we have covered to this point? Any new insights you've had? What have you learned the most that surprised you?
Type 2 being hereditary.
What? Say it again,
People
Laura.
saying type 2 is hereditary. I normally don't associate that to be hereditary.
Really, it's more hereditary than type 1. So it's a big, much more load. But just like with type 1, we'll see with type 1, genetic predisposition. But in type 1, if you don't ever come across the trigger or encounter it, the disease doesn't manifest itself. But with type 2 diabetes, the lifestyle can really manifest it earlier. Okay, good. What else?
Viruses can incite type 1.
Viruses can incite type 1. Okay. Because it's an immune. So we'll talk about it today. I'll show you some complicated pictures that I don't understand, but it's just a very complicated process, and it's a long process. It doesn't happen overnight as well. What else?
Just how far the disease can go without symptoms.
Yeah, and that's scary, yeah. So very insidious. What else?
Gestational diabetes, that it can lead to normal diabetes too afterwards.
Yeah, very important to remember that. Because you wanna get those women educated and engaged in the system, because for the most part, they're healthy. So they're not gonna be seen that often. Some of them don't even have primary care providers. Even when I was at the college, a lot of my young colleagues didn't have doctors. Now, they went to an OBGYN, and a lot of OBGYNs do a lot of primary care because that's a common doctor for the women to see. I've noticed that with the physician I go to, in just talking to her and listening to what she does, lots of primary care. Kendall?
I was just wondering if you ever referred any of your patients that were pre-diabetes or that were maybe in environments they would be predisposed to it, to any of the health department programs that they have for heart health and management of weight and
You know, we didn't, because we did it all in-house, but we would occasionally, we would make it known. Our dietitian was really good about that. We would post where there were opportunities. So the health department did do a weight loss program. And they won't reimburse dietitians necessarily just for weight management. So we would make them, let them know about that. I don't know how many ever took advantage of it. I know she worked a lot. Did you have?
well, I just know that like OU physicians, they partner with the health department, the new one that's.
The one on 23rd, you mean, or the?
No.
Oh, the one up on, by the Remington Park?
Yes.
Yes.
That one and the one in the South Clinic. And there's a lot of free resources that don't get used, so I didn't know if they ever like really referred them or not, but.
I think they referred them more based on economic status, and, you know, if they couldn't afford care, they could go there. Now, we did use their facilities, our group did, because they have a great walking path. So our, Fanny, who you've met, and our dietitian used to hold classes up there, because I think they had a kitchen in there. So we did several cooking classes with them. The other thing we would do is we would walk them. So what we would do is try to show them what a exercise would do to their blood sugar. So we take their blood sugar and then we walk them through the trail, and it's not a very long trail, but it would take some of them a while to do it. And then we would check their blood sugar after it, and they were amazed because it would drop 20, 40, some of them even 60 points. So we did use that facility. It's nice. They got some good stuff there. You're right, it's underused.
That My Heart program, it finds a way to pay for their insulin and things if they will stay with it, and they only have to talk to them once a month, but I didn't know how many people actually would do it, so.
I don't know about, I didn't know they did that. We had a huge sampling supply, so we usually supplemented most of our patients, so I didn't know about that part. But there's all kinds of stuff there. We worked towards getting a coalition of diabetes, and there are some people there is a diabetes coalition that works more on legislative matters. We tried to form one for just, because people are doing little pockets of things everywhere, and there's not really anything that brings them all together so that you can have it integrated. But there are a lot of people working towards it. There's just barriers. Some can get funding, some can, it's just a mess. There's nothing united. But there's lots of people doing lots of things in different communities. Anything else? Any other insight?
I guess more so I have a question. What's like your number one tip for starting the conversation on lifestyle change and really like being able to talk to them about that where they will hear you?
Okay, good. So here would be some different approaches. I assume if people show up at an appointment for diabetes, that they have some degree of interest and they are looking for help. So I just start at that point. I usually do a lot of asking. How do you do this? How do you feel about this? Tell me more about this. Why do you choose to do this? How is that working for you? If you binge on Oreos at night, how does that make you feel the next day? What motivates you to do that? In some of them, it's psychiatric issues, and it's getting them with a counselor to help them. So I just do a lot of listening. Then I ask them, and I'll ask them, what do you want? What do you, in coming here, what are you expecting? Well, most of them will tell you, I want better blood sugar control. Or some will tell you, I don't want to lose my leg. Because in the African American community, that's pretty common, a complication due to smoking, just poor health, poor choices. So I'll say, okay, here's what it would take, and I outline them. Here's what we're looking at. And then I'll ask them, what can you take on first? And so I'll listen to them. Usually they're most motivated, they want to know is what can I eat? So I tell them, you can eat whatever you want, it's how you choose it and how much. I never talk about food being bad, I just don't. I might say it to you all, but I never do that with a patient. If patients start talking to me about, oh, I ate all that stuff I shouldn't, I just throw that stuff out because it brings in guilt, it makes food weird in terms of the way people look at it. So if you can just start deconstructing all that and reconstructing. If you have to have a candy bar every day, then let's talk about how to do that in a way that doesn't wreck your blood sugar. Okay, can you buy the little fun size, and we set a limit on how many you do. I had a lady one time who said, if you take my candy bars away, I won't come back and see you. Okay? And so she said, I'm just going to tell you, I carry a candy bar in my purse with me all the time. And she said, knowing that it's there and I could have it if I want it is comforting to me, but I never eat it. I'm like, okay. She goes, but if you tell me I have to leave it alone, I'm not coming back, and I'll go home and I'll just binge on it. Like, okay, that works. I'm not. So people have weird things surrounding food, so I'm just taking it off. The only time I sit down and say to people, you have to stop doing this, is sodas. You cannot control somebody's blood sugar when they drink sodas. You just can't do it. It's too quick, it's too powerful, it takes too much insulin, and I'll blow you up 50 pounds in no time. So that's the only food I tell people, you have to leave it alone. I've had people not come back. Very few, but
I had gestational diabetes, and the doctor that would tell me to stop eating, I switched OBGYNs because he would tell me to.
he told you what?
Yeah, he told me to stop eating. He's two things.
Stop eating.
Like, I'm eating too much. He didn't
Yeah.
tell me to stop eating. He said, I'm eating too much. And so I didn't like that. And I wouldn't comprehend that I'm getting fat. And I went and saw, they referred me to a nutritionist, and everything she said was like, even though, I have good medical background, I know what I'm doing is bad, I just wouldn't listen. Everything she said, I sat in that appointment, she would show me the lettuce and all these things, and I'm like, okay, that was the longest hour of my life. I went back, I had a burger, and I switched to a nicer doctor that didn't limit what I ate. The other one was really mean about it. He was like, you're getting fat, you have to stop. And so that's what happened. You have to, people don't think.
I say for both of my in-laws have diabetes and hypertension and everything, and in my mind, I'm like a 4-year-old and 6-year-old grandson would be motivation, just stop. And
Nothing.
zero motivation. She literally told me I'll probably never really get to know your kids, kind of thing. So it's heartbreaking for me that these patients are in that place.
So I do ask people in knowing them and talking to them for a long time, I knew my patients well. I could tell you, when they sat down, I could tell you about their grandchildren. I could tell you who they rooted for. I could tell you where they had been. I could just tell you. So I think the more you have relationships with people, if that's your forte, they'll stick with you, and they'll tend to do things more for you than if you don't have a relationship. If you're coming in and playing strictly the provider role, it just won't work in the long term. It will work for some people, but the majority will leave you and find somebody else. Samantha?
At the pain clinic I worked at, we had a lot of diabetic patients, and it's really interesting how much people don't know and or understand about the disease itself, and how much they don't know about nutrition at all. Like, we had a patient with an A1C that was like 13.5, and she was convinced that it was that high because she was chewing gum.
Yeah.
And it's like,
Yes.
that's not even close to how this works. And then there was another patient who also had like an 11 or 12 A1C, but refused to admit she was diabetic. She's like, well, I might be insulin resistant, but I'm not diabetic. And it's like, you know, they just need so much education on being able to understand that, because otherwise they're never gonna have control of their blood sugars, because they won't make their diet changes because they don't know what they are that they need to make, and they're, I guess, afraid of having that diagnosis in the first place.
That's true. Ron, and I'll come back.
I was just gonna comment that it might be a good place to use some of the motivational interviewing type training, so if that's something you're interested in, that's, I mean, there's a lot of training out there for like motivational interviewing for like substance abuse and things like that. That's where I came across it before. We were looking at using that for a brief intervention for pregnant mothers that had substance use issues. But it seems like you could apply that same thing to any type of, you know, like you said, maybe the grandkid or whatever is not the motivation, but usually if you use these techniques, you can get to their underlying motivation, find something that will help you initiate change thought in their behaviors. I don't know.
So that's what you heard me say when I was like, okay, what are you willing to work on? So I let them self-identify, and then I see where they are and how far are they willing to move. Kendall?
Would it be appropriate to send them to a diabetic educator like we do with asthma, you know, since it is that long?
Absolutely.
I mean, I just didn't know how useful that is in a practice, or, I mean, I don't know.
Every diabetic you see ought to have diabetes education that is willing to attend. Here's the other way I start, is that I assume everybody has the right to choose. And they have the right, it's their life, their body, they can choose, as long as they are making an informed choice. The other thing is you have to, when you talk about the motivation of a young child's not being a motivator, it's their life. I can say that makes me sad to hear you say that, but it's their choice. So I come from that. I am not your mother, even though I will act like that, and I'm your coach. I will stay with you. People change over time. Like Samantha said, those patients she described, you'll run into those and you'll just think, you're crazy. But sometimes it's where they are. I meet people where they are and I move them along as they can go. And I stick with them. So diabetes is a huge burnout for most providers. It'll wear you out because it's this course. They do really well and then they fall down and they go right back to what they were doing, and then they get motivated, they do better, and then they fall right back down. I'm talking more about type 2s. Adults, changing lifestyle, it's hard. So I think I'm good at diabetes because I can do that. I can walk with them to the point where they drop dead. But other people, it's hard. It's a hard disease to deal with. But that's how I approach. It may not be the right way. It may not work for everybody, but that's how I do it. The other is that what you'll find is that I've seen endocrinologists who, if you don't do what I say, get out. I've got other people to work with, and they do. They throw them out of their clinic. Here is one of the downsides of the government coming in and say, you have to do this. They are going to hold you accountable for a patient's behavior. It'll drive you nuts. They're like, you're not doing this. You're not getting these accomplished. Well, if your patient doesn't show up, if your patient refuses or they won't do it, you can't make it. So what they do in those circumstances is they drive practices to say, you can't be in my practice. They'll dismiss you. They will fire you as a patient because you don't do what I say, you'll make my numbers bad. When I was pregnant with Cameron, my physician was, he was like, I have the lowest C-section rate in this practice, and your weight gain is not going to lead to a C-section, it's going to ruin my record. If I had not been so far in the pregnancy, I would have walked out. I thought, He was a good doctor in that he did what was right for my safety, but he was a terrible it had terrible personnel. Anyway, I only gained about 23 pounds in my pregnancy, but in 1 month, I gained like 4 to 6 pounds, and then it slowed down. But he was a Nazi about it. So I get it, I hear you. Anyway, other questions?
How would one go about making a referral to a diabetes educator?
Okay, so if you're in a system, like OU, big system, we had 2 or 3 on campus. Some of them catered, we had one was just for high-risk OB. And then we had 2 that were, one in family medicine, one in the endo. So usually you find out where they are, and there will be a referral system. In a system, usually in your electronic medical records, you just fill out the form, it goes, and they take it from there, just like any referral.
So it's not like their own practice, they're just, other healthcare professionals with that certification?
Could be, they could be just diabetes educators, they could be.
Okay.
Usually in like a hospital, they will have a department that's what they do. They're hired just to do that.
Okay, so from like your experience, would you come to the clinic that you got referred to and talk to them, or do they come to you, or, I've never heard of that before.
Okay,
We had one that came to us, she practiced down here and she worked with multiple clinics in areas, but she would come up once a month and usually just have a lunch with us and see if we needed anything, and then also would schedule if we wanted to set patients up for a clinic. But I think that she actually was also affiliated as a drug rep.
so the drug companies, they do that. They hire educators to go out and do that. And they also work their products in with it. But they do pay for that. That's not the norm. The norm is that people have it set up in organizations for the most part. So our clinic, we had a diabetes education, that was one of our services. Anybody in the city could have referred into that. We mostly catered to family medicine and then people on campus. So,
But it's because I know we had some at the VA, but they were all dietitians too, so it's like an extra certification, right? You can't just be because it's 1,000 hours or something of teaching people with diabetes to get it, correct?
right. So in the VA, they have their own system. It can be, you all could be certified diabetes educators. You have to meet the criteria. It is a certification, it takes 1,000 hours of documented education, then you have to take a certifying exam. But it's usually going to be a nurse, a dietitian, or a pharmacist. Those are the 3 major ones that do diabetes education. So find out where they are on the ADA website and the AADE website, they have listings of programs and you have to be accredited. So you have to be accredited in order to bill. Anybody could say, I provide diabetes education. They can't bill for it unless they're certified and they're a certified program, accredited program. So there's a standard they have to meet, there's curriculum they have to meet, they have to gather data, they have to reapply and recertify. So I think I've got it somewhere to talk about that more, just to let you know. Any other things? Good questions. Okay, are your brains awake and ready to go? Okay, so let's go back and look at this again. And remember that with type 2, foundation is lifestyle, metformin, drug of choice. And then after that, it really is more catered to the person. So it's more what drug you choose next will be based on the person's patient characteristics. Are they a fall risk? Are they going to monitor? Do they have other diseases that would contraindicate the use of a drug? It may be cost, it may be insurance. So there's these on the side give you a lot of insight as to which drug to choose next. A lot of what will drive me is how far do I need to go to get to a glycemic goal? If I know clinically, so I'm telling you it's important to know that, if I know what the potential of a drug is to lower their A1C, that will drive what I choose. That's why in the beginning, if I'm dealing with someone who's got an A1C above 9%, I'm going to be looking at metformin and then adding a sulfonylurea because I know I can get to goal. But I never, never leave food alone. I never leave exercise or activity alone because it will always enhance what the drug does. And I can get by with less drug. Always my goal. Okay, so the TZDs, the thiazolidinediones. There is one currently in, well, there's two. There's another one called rosiglitazone. This group has had a very hard time staying with an active member. The first drug that came out in this group is called triglitazone, and it probably came out in the early 90s. It caused liver failure enough times and death that they took it off the market. The other two that then came on are rosiglitazone and pioglitazone. Rosiglitazone almost got the FDA X because of increased risk in cardiovascular events. They got it to the point where they specialized it to where only the people who were still on it could stay on it, and only certain physicians and groups could prescribe it. They have lightened that somewhat, but they pretty much killed the market for rosiglitazone or Avandia. So the one that's left is pioglitazone, that's Actos. It is a generic at this point. It's been around for a while. So what are the contraindications, what to think about? First is, it is a drug that causes edema, and it can cause significant edema. So it can worsen heart failure. So if you have class 3 or class 4 heart failure, it's recommended you not start that drug. It can precipitate new onset heart failure in someone who didn't have heart failure. Causes an anemia, but the anemia is a dilutional anemia. So it doesn't cause an iron deficiency anemia or any kind of blood loss. It just, because of the volume of fluid that is retained, it's a dilutional anemia. Impaired liver function was problematic with the older, not so much with the newer agents. So I'd say that is a lesser problem, but if you have somebody who has significant liver disease, probably you can use other drugs. They're safer drugs to use. Would not use it in type 1, would not use it in pregnancy. It just doesn't help in pregnancy. So it's not a teratogen, it just doesn't work. So what can you expect from a TZD? One thing to keep in mind is this drug, because of the way it acts, it takes about 3 months to see effects from the drug, maximal effect. Okay? So it's not a quick. Metformin, sulfonylurea, the day they start taking it, you'll start seeing effect. Okay? Average decrease is 1.5%, but let me tell you that the effect is very wide, the range. The population I worked in, I never found it to be a very effective drug. I find it more effective in people who are very new onset, have high degree of insulin resistance, and probably not that high of blood sugar. That's who I saw tended to have the most effect. Can be used in combination with almost any of the other drugs. Initially, people like to use it with insulin because it improves insulin sensitivity. It's very variable, though. You see the average decrease there of 0.8 to 1.3%, so it's not as predictable. I can tell you metformin, sulfonylurea is very predictable in what they're going to do and the power that they have to lower A1C, as long as the patient isn't out eating what you're trying to do. It's pretty easy to take, once a day drug. The problem I have with this is the amount of side effects. So here are the side effects. Weight gain. The average weight gain with the TZDs is about 11 pounds. I have seen up to 50 and 60 pounds with that drug. It tends to redistribute fat. It tends to move it from more central fat to peripheral fat. It's still fat. I mean, we're telling people, I want you to lose weight, I want you to lose weight, and then we put them on this drug, and it can be a powerful drug in that area. Edema, a lot of it is lower peripheral edema, more gravity dependent. Anemia, the dilutional effect I talked about. Heart failure, new onset, also worsening of existing heart failure. Odds ratio 2.1. An odds ratio of 2.1 is high. High likelihood. It occurs at any dosage level, likely to occur after several months of treatment, but can occur at any time that people are on it, all age ranges. It decreases bone density. So where they figured this out was in a study, was it actually in the ACCORD study, and older women started having upper arm fractures more often. So the receptor it works on is also in the bone, and it decreases or increases osteoclast activity, and so they resorb bone at a greater rate. Sorry, it was the adoptrel, not the ACCORD. Increased risk of heart disease. This is a small increase. It was mostly with pioglitazone. Increased risk of new diagnosis of heart disease and MIs. Macular edema. This was more common in people who had heart failure and already had fluid overload. Increase in serum transaminases. That's a rare. For that reason, I don't like to use the drug. So this is my opinion. I just don't find it to be that effective. And I don't like all the side effect profile. That is my opinion. You will find it a lot. Endocrinologists use it a lot. People keep folks on it. The other thing is with pioglitazone that came out in the last few years, an increase in bladder cancer. And in men. So I don't know what it takes to kill off the drug, but they're still there because they are one of the few drugs that is powerful enough in terms of decreasing insulin resistance. But I feel like you pay a big price for it. That is my opinion. I never found it to be that helpful or strong. They were very expensive drugs when they were brand, so adding them I didn't feel I was getting the money, the bang out of the buck. They're now generic, less expensive, so that kind of goes away, but still, you really have to monitor these folks. Now, since they don't affect insulin production, they don't cause low blood sugars. They also can be used in people who are on dialysis. So there's not that many drugs outside of insulin that we can use for folks on dialysis. So there are niches where I think they may be helpful. So the way they work is they work on a nuclear receptor in the cell. These are the peroxim proliferator activator receptor, PPAR gamma is the way most people refer to it. These receptors are all over the body. That's why this drug has such, the side effects it does, is because it's not a target, it doesn't have a very limited target. It binds to that receptor and it increases the GLUT4 transporters. So you can see how that decreases insulin resistance. So when insulin sits on a receptor on a cell, GLUT4, those transporters that bring glucose into the cell that are activated, it increases the number of those. So that's how it decreases insulin resistance. And then at the higher dosage end, it also decreases hepatic glucose production. Not to the same extent that metformin does, but significant enough for some patients. So on the page 12, you've got a picture of it. Works in the liver, works in fat, works in muscle. So those are your three high insulin resistant organs, and so that drug helps to improve sensitivity in those organs. Questions about the TZDs? Okay, let's move on to the DPP-4 inhibitors. So these are naturally occurring, so the DPP-4 is an enzyme that inactivates your incretin hormones. So GLP-1, GLP-2 are inactivated by this enzyme. So the thought is that if we can knock out that enzyme, then the natural incretin hormones will stay around longer. So what was the action of what's the target organ of the incretins? GLP-1, GLP-2. Stay with GLP-1. Where's its target? the receptors are, they're made in the L cells of the intestines, but once they're secreted, where are they targeting? Pancreas. What do they do in the pancreas? Based on plasma glucose, they increase incrementally the amount of insulin that is released. Okay. So if you look down at that, I don't know if you can tell out of that little picture I put at the bottom, you can see the DPP-4 neutralizing the GLP that is produced. And so what this drug does is it just takes out those enzymes. So it increases the longevity of your naturally occurring GLP-1s. There are several in this class. Januvia or sitagliptin was the first. That's the one I'm going to use as kind of the standard of the class. They differ a little bit, but I want to use sitagliptin because it has dosing limitations with regard to renal function. So one of the prescriptions that you have to write is for Januvia, and you have to figure out the creatinine clearance for the person before you can prescribe the dose. Okay. So the dosing ranges from 25 to 100 milligrams a day, once a day. And how much you give them is based on the creatinine clearance. So what can you expect in terms of a drop? About 0.6 to 0.8. So not a whole lot. I don't see a whole lot with them. I'll use them as small additives if I'm buying time to get to insulin or letting them work on lifestyle changes. It's rare that they are used as first line. You can add them to metformin. I just don't see huge effects. They're very expensive. And so for the money that you're spending, you don't get a lot of drop. But they are part of your toolbox, your armamentarium, so keep it in mind as you're adding. It is usually a third drug that I add. And usually it's when I'm buying time to get to something else. That is my approach. That's based on my experience. They're usually fairly well tolerated. They don't have a lot of side effects, but they do have some serious side effects. They do have serious hypersensitivity reactions, so anaphylaxis, angioedema, exfoliative skin conditions like Stevens-Johnson syndrome. So those are bad. You can die from those. But they're not very common. So it makes the drug relatively safe. Also, people tend to get upper respiratory complaints, runny noses, head congestion, kind of odd. I'm not sure why that is. That's about it. I don't mean to downplay them, but they're not very powerful. You'll see them used a lot as add-ons, but I don't expect a lot out of them.
I was going to ask, I was reading your objectives and it asked for contraindications. Is there anything besides like it needs to be renally adjusted?
Renally adjusted is your big one, would be the big one. The other is if people have had a history of Stevens-Johnson syndrome or severe skin reactions, erythema nodosum, if they've had something like that, I would not use them. Now that's me. I don't know that if it's listed like that as a contraindication, but I would avoid them. Somebody else had a hand up.
That was my question.
Okay, sorry. All right. Okay, let's move to the GLP-1 agonist then. This product's probably been around 10 to 15 years now. So the first one on the market was Byetta. Byetta was actually a synthetic, it's called Exendin 1. It's a synthetic GLP-1. They harvested from the Gila monster, from the saliva of the Gila monster, is its claim to fame. So if you look at a glucagon-like peptide, that's GLP-1, this is what it would look like if you're laying it out. These products are made to look like endogenous GLP-1. They're eventually broken down to this is your agonist part that interacts with the receptor, and then it's inactivated by that DPP4. So all of these are inactivated by DPP4, but they are very resistant to it. So your natural endogenous GLP-1 probably is a matter of a few minutes. These GLP-1s, their half-life is like 24 hours. Okay, so they're very powerful. So the resistance to breakdown is high. Okay, let's look at their mechanism of action first, because they do several things. So again, you have that GLP-1 that's made in the gut. So we're giving it to them in an injection. It does several things. One is it slows down gastric emptying, so they feel fuller longer. It also, its action on the pancreas, it causes a greater increase in insulin, so lowers the blood sugar. It causes a decrease in glucagon release, so the effects of glucagon on hepatic glucose output goes down, insulin release goes up. The other thing this drug does is it has central effects. It works on the anorexic center in the brain. I think that's in the hypothalamus, but don't hold me to it. What it does is it causes the person to have an early sense of satiety. So what's satiety? You feel full. You feel like I'm satisfied from what I have eaten. So these folks will feel earlier into the meal that they've eaten enough. That is where its weight loss effects have come from. It also makes them sick to their stomach. They get nauseated, they vomit, but that's not what causes the weight loss. It's that early satiety, and it can be significant. I'll give you some stories about that in just a bit. There are 5 on the market. Well, let's look at these. This is good. So this is GLP-1 concentrations on the y-axis. On the x-axis, it's time. So normal glucose tolerance, meaning how well you can handle a glucose load, is in the blue. So you see the GLP-1 hormone levels are, this would be normal. If you have impaired glucose tolerance, which would happen in a pre-diabetic, you can see that the incretin response is diminished. And in those with type 2, it's greatly diminished. Okay. So you have lost one of the factors that increases the release of insulin when blood sugars go up. Okay. Here's another way to look at it from plasma glucose. So glucose levels on the y-axis over time is on the x-axis. Here is people without diabetes in the blue. Here are people in the red. What they're showing you there is the lack of that incretin effect. So without it, blood sugar levels are much higher. So here is using Byetta, one of the GLP agonists. On the y-axis, you have glucose. On the x-axis over time. Here is an injection of the GLP-1. Here is a standardized breakfast. Here is placebo, and you see the blood sugar go up. Here is Byetta. So in the presence of that GLP-1, plasma glucose concentrations are much lower because they can produce more insulin. So they're very powerful drugs, and are fairly new compared to all the others that are on the market. So Byetta is the oldest, then Tanzian, Trulicity, and Victoza. If you look down through their dosing regimens, what you'll see is that Byetta was a twice-a-day drug, Victoza was a once-a-day, And now we have Tanzium, Bidurion, and Trulicity, which are once a week. So those are great. The way I do that with folks is I usually start them off on Victoza or Byetta, because the Byetta is now one of the cheapest ones, so usually insurance will drive you that way. So I usually see if they can tolerate it. I would say in the patient population I've used it, it's about 50-50. And I usually know within the first week, because people they'll be seriously ill. Nausea, vomiting, can't tolerate it. If I can get past that and they do well and they stay adherent on it, then I move them to the once a week. I don't usually start people out on the once a week, because if you start them off on once a week and they can't tolerate it, that drug is hanging around for a week. So that's my approach. Others I know do start people out on the once a week. I usually have them pick a day of the week. So Sunday or Monday, whatever you're going to do it on that day. Okay. You'll see also that I start with the lowest dose just in case they really have a bad reaction, and then you can increase it based on their response. Almost all people will lose weight on these. The average, they say, is about 4 kilos or 4 pounds? Pounds. But for people that I've had that have stayed on it, I have seen much greater weight losses, 10 to 20 pounds. There's a group in Washington State, an endocrinology group that I have gone and listened to them give their talks. They were one of the first groups to do a lot of the studies with the GLP-1s. They had super losers. They had people that lost up to 60 pounds and continued to lose. So some of these drugs are seeking FDA approval as weight loss products. And it's that early satiety. Here's an example of one of the ladies that I used or took it in my clinic. She was sent to me, sat down, talked to her, and you'll run into these patients where they have been on every drug and they can tell you why it's not good for them. So at the end I'm like, you have left me with no options. Your A1C is over 11%. Your doctor sent you here to start on insulin. You're refusing insulin, but you've wiped out every other drug that I can use. What do you want me to do? Because it's like you've closed the door, you have figured it out, you are so smart, and I don't mean that in a bad way, but you have thrown up a barrier for everything I can do. I said, there's one drug left, and I told her about this group. I said, usually on average, you only get about a 1% decrease with the GLP-1s on average. I said, I don't think it's going to get you to goal. And it's an injectable. She wasn't opposed to an injection. She didn't like the fact that insulin would cause weight gain. So I told her, here's all the options, here's the good and here's the bad. She said, I'll try it. I said, okay. I gave her enough sample for 1 month, and I scheduled her back to see me. I said, if it makes you really sick and you can't tolerate it, call me before then. I didn't hear from her, but about 3.5 weeks, I did get this message to call her that said, has run out of insulin, blood sugar's running 300, need to talk to you today. So I called her, and she'd been running 300s before. She said, I have got to have more of that drug. I can't wait until I see you. And I said, well, okay, tell me what happened. She said, well, I started taking it. Within a few days, I was running blood sugars of 100. I thought, there is no way. But I said, okay, come in. I'll get you we'll get you some samples, but I want to see you. So in talking to her, she did have that satiety and eating, what made a big difference. Her blood sugars were around 100. It was incredible. She had been running 300s. And she had lost, probably in that month, had lost about 12 to 15 pounds. She said, I feel satisfied. She said, I can get up and I can leave the table. She said, it's no problem. She said, I love this drug. And so her A1C went from 11% to around 7.7 on that drug alone based on food. I'm telling you, most of the time with type 2s, it's the food. And you got to address it the best way you can, or as much as they can. So I have had some amazing experience, or patients have on these drugs, but I've had some within a week, they're throwing their guts up and they're like, get this away from me. So those are my experiences with it. I like the drug. If I can get people to tolerate it, I will use it. In a lot of practices, what I'm hearing people do is after metformin, this is usually the first drug they're going to because of the lack of weight loss, or because of weight loss. And because of this experience with getting those blood sugars down to near normal because of the increased food intake. So let's talk about who's contraindicated. Number one, type 1s, you would not use it in. Even though they secrete incretin hormones, it is not recommended for type 1s. If they have severe gastric disease, don't put it on them, it will just make them sicker. Don't use in people with a history of pancreatitis. So these drugs can cause severe necrotizing pancreatitis. Early on, I saw one patient develop this and die from it. So you got to do a history if they've had a history of pancreatitis. Gallstones, alcoholism. So sometimes you can get alcoholic pancreatitis or alcoholic ketoacidosis. Elevated triglycerides, usually all of those are pancreatic related, so you increase the risk of that more severe side effect. For Byetta, you can't use it with creatinine clearances less than 30. Other of the drugs you can use in renal insufficiency. Here's the big one, and this is pretty much considered now a class effect. Do not use them in people who have a history of medullary thyroid cancer or a family history, because it increases their risk. Or if they have multiple endocrine neoplasia syndrome, type 2, MEN2. People will know that. If they've had it, they'll know that terminology if you use it. That is a big one. I'm sure that will show up somewhere in assessments, okay? Is that you've got to ask people about it. In terms of what to choose, a lot of times what's going to drive this class is what insurance will pay for. That has been my experience. And so I usually find out what is that first, and that's what I go with. The drug companies are pretty good about giving you samples to start with because you've got lots of competition in that group and they want to get that product out. There are some differences in terms of mixing. Some of these, like Bydureon, you have to mix before you use. So I look at how easy the drug is for people to use. This is Bydureon. It comes as a pre-filled pen, but it also comes as a vial that you have to mix with the diluent that's in the syringe. You have to pull back. So it's a little bit more prep time than you would have with a pre-filled pen. It was the first formulation that came out. Victoza is pretty easy. It's pre-filled. The only thing I don't like is that it's a one syringe or one pen for everybody. And so as you increase the dose, instead of it lasting 30 days, it's 10 days. So you really have to, if you're titrating the dose, have to keep that in mind. Here's Victoza. Victoza's effect on insulin production. So this is Victoza, this is placebo, and this is insulin on this axis and glucose on that axis. So a very, very significant response. Here's Tanzium. I don't like Tanzium because you have to wait. So to me, the more high maintenance a drug is, the less likely people are to do it. But it still works. And Trulicity, I love the most because it is pre-filled, ready to go. You don't have to do anything to it. It's also the most expensive. And this, I think, is the one I may have given you as a prescription. The other thing I like about Trulicity, it comes with a needle built in. You don't have to write a separate prescription for the needle like you do for the others. So these, if you look on page 15, they're all pre-packed, ready to go. So when you get, like Byetta, when you get it, you've got a month's supply in a pen. Victoza is the only one that is an exception to that rule. I usually, and I'm titrating it, I go at least a month in between dosing increases, just to get tolerance to that initial dosing. Now the patients are doing really well and they're having no problem. I may let them go ahead. I'll give them a self-titration schedule, or I'll call and we'll talk about how they're doing before we go up. But that's the only its tolerance with that is, I find. Clinical effect, I gave you 1 to 1.5, about 1% is common. Side effects, so dose-dependent nausea. So I'm on page 16. The hemorrhagic and necrotizing pancreatitis, screen your folks well. Other than that, I've never had any other patient that's developed it. Serious hypoglycemia. The drug by itself does not cause hypoglycemia. If you put it with other drugs like a sulfonylurea, or you can use these drugs with a basal insulin, then the risk goes up significantly. It's more than using the insulin or the sulfonylurea by itself. So if you look on that chart, it shows you which of them have been approved to be used with the basal insulin. I have found that to be a very powerful combination. It's not approved to add bolus insulin on top of it. I've seen people do it, but the risk of hypoglycemia goes way up. So be very careful on those if you're in a situation to prescribe it. Byetta does have a significant drug interaction, and that's with drugs that need rapid transit to get absorption, like levothyroxine, the thyroid drugs, or antibiotics. Spacing of those drugs becomes important. I would say most people don't use Byetta unless they are forced to by insurance. It works, but it just has a lot more things you have to worry about. It's twice-a-day dosing, renal function, and then the spacing of other drugs. Remember I told you in the very first module that drugs that are now, once they're on the market, the FDA has the right to require you to prove certain things post-marketing. With the drugs that are glucose lowering, they have to show cardiovascular safety. This is one of the classes that came under that scrutiny. Victoza has shown that it does decrease cardiovascular risk. So in this class, that drug has that FDA approval for that. So you might consider it if you have somebody who has high cardiovascular risk in using that drug or choosing that one over. Y'all are looking at your handout, or is this not in here? Or are you not keeping up with me? I am on page 16.
I think that's page 14.
Our page number.
Oh, okay. See, I modified yours after I ran mine off. Sorry. Okay. Questions about any of that? Great class of drug. Takes some drug. One is the big barrier is I don't want to inject. But when they get to it's either insulin or this, a lot of them will choose this class because of the weight loss, once a day, ease of use. Sakaba?
In the handout, it says the average A1C drop is 0.9%. If the PowerPoint says 1 to 1.5.
So the difference comes from the different drugs. So Byetta is about 0.9. So the others had different ones. I would remember about 1% is about, and that's average. But I'll tell you what, I've seen some big drops. If it really impacts their eating, you'll see even bigger. So on average, about 1%. Anything else? Okay, let's take a break. We'll start back at 10 after.